Hello, so today we are going to discuss motor neuron disease. Motor neuron disease is also known as amyotrophic lateral sclerosis in some countries. It is a devastating condition causing progressive muscular weakness and eventually death because of respiratory failure and aspiration. It is an uncommon condition and the age of onset is usually between 50 and 75 years. In motor neuron disease, upper and lower motor neurons are affected in the spinal cord, cranial neuromotor nuclei, and cortex. However, other neuronal system may also be affected. For example, in 5% there is frontotemporal dementia, and in up to 40% have some measurable frontal lobe cognitive impairment. It is a sporadic disorder with unknown cause and no established environmental risk factor. So now let's discuss some of the distinctive clinical features of motor neuron disease. So it is a disease which usually occur after the age of 40 years. So it rarely begins before the age of 40 years, and there is no sensory involvement. Sensory symptoms or signs are not seen. Similarly, ocular movements are not affected. No involvement of ocular extraocular muscles. There is also no involvement of cerebellum or extrapyramidal tracts. So no cerebellar or extrapyramidal involvement. Sphincters are also spared, and if they are involved, then that is late in the disease course. Remission is unknown and the disease is fatal within 5 to 7 years caused by bronchopneumonia. Similarly, there is upper and lower motor neuron involvement of a single spinal segment and motor dysfunction involving at least 2 limbs or 1 limb and bulbar muscles. So these are some of the distinctive clinical features of motor neuron disease. For example, sensory involvement, no extraocular muscle involvement, no cerebellar or extrapyramidal involvement, and no bladder or bowel involvement. And the disease is fatal within 5 to 7 years and usually caused by bronchopneumonia and rarely begins before the age of 40 years. Now let's discuss the pattern of involvement in motor neuron disease. There are basically 5 patterns of involvement in motor neuron disease in which a patient may present to the clinic. First, let's discuss progressive bulbar palsy. Progressive bulbar palsy is predominantly cranial nerve involvement in this, especially cranial nerve number 9, 10 and 12. When there is involvement of cranial nerve number 9, 10 and 12, this is called progressive bulbar palsy. Early involvement of the tongue, palate and pharyngeal muscle, dysarthria and dysphagia predominates in this pattern. Wasting and fasciculation of the tongue, and there is pyramidal sign. The second pattern in which the motor neuron disease may present is Pseudobulbar palsy. In Pseudobulbar palsy, there is also involvement of cranial nerve number 9, 10 and 12, but there is upper motor neuron type of lesion. So these two are the clinical pattern in which the motor neuron disease may present. Other than this, there is amyotrophic lateral sclerosis. In amyotrophic lateral sclerosis, there is predominantly mixed upper and lower motor neuron type of lesion, like distal and proximal muscle wasting and weakness, fasciculation, spasticity, exaggerated reflexes, extensor plantars, bulbar and pseudobulbar palsy may follow eventually, and there may be pyramidal tract features. Fourth number, progressive muscular atrophy. In progressive muscular atrophy, there is predominantly lower motor neuron type of lesion. There is weakness and wasting of distal limb muscle initially, fasciculation and tendon reflexes may be present. The last type is primary lateral sclerosis. In primary lateral sclerosis, there is predominantly upper motor neuron type of involvement, like spasticity, and it gradually progresses. All of the following type merge into motor neuron disease when the disease progresses. So let's summarize. Number 1 is progressive bulbar palsy. In progressive bulbar palsy, there is involvement of cranial nerve 9, 10th and 12th. In pseudobulbar palsy, there is involvement of cranial neuron 9, 10 and 12, but upper motor neuron type of lesion. Now third is amyotrophic lateral sclerosis. In amyotrophic lateral sclerosis, there is mixed upper and lower motor neuron signs, while in progressive muscular atrophy, predominantly there are lower motor neuron signs, while in primary lateral sclerosis, there are predominantly upper motor neuron type of lesions. Now let's discuss what important investigations are done in motor neuron disease. Motor neuron disease is usually diagnosed clinically, but some tests are performed to differentiate it from other treatable causes in which there is involvement of upper and lower motor neuron, like syringomyelia, etc. So the first test we perform in motor neuron disease is electromyography. In electromyography, there will be signs of acute and chronic partial denervation with renervation. So on EMG, there will be signs of denervation with renervation. In patient with suspected ALS, diagnosis should not be made with confidence unless such changes are found in at least 3 spinal segments, that are cervical, thoracic and lumbosacral, or 2 spinal regions and the bulbar musculature. We also perform neuroconduction study, but that are usually normal. Like the motor conduction study may be slightly reduced, and the sensory neuroconduction studies are normal. Biopsy of arrested muscle show histologic changes of denervation but is not necessary for the diagnosis. Serum creatinine kinase may be slightly elevated but never reaches to the high values such as seen in dystrophies, other muscular dystrophies. The cerebrospinal fluid is normal, and to diagnose spinal muscular atrophy, molecular genetic testing may be performed. So on EMG, there will be signs of denervation with renervation, and on conduction study, there will be slightly reduction in the motor conduction velocity, and biopsy is not necessary for the diagnosis, while the serum creatinine kinase level may be slightly elevated. Now let's discuss the treatment of motor neuron disease. As there is no treatment for motor neuron disease which could reverse the disease progress, but still a number of drugs are approved by the FDA for use in amyotrophic lateral sclerosis, that are riluzole, sodium phenyl butyrate, edaveron, a pre-radical scavenger, and ultra high dose of methylcobalamin. All of these drugs could be used and may result in improved survival. Riluzole can be used to improve the survival by 3 to 4 months. Other than this, we give symptomatic treatment and palliative care. But for the disease progress, we use riluzole, sodium phenyl butyrate, edaveron, and ultra high dose methylcobalamin. Now for the symptomatic relief, the following treatment should be done. For example, for fasciculation, we can use magnesium or vitamin E, quinine, carbamazepine, and phenytoin. For spasticity, there should be physiotherapy and other support for spasticity, along with the drug treatment like bedopin, tizanidine, memantine, and tetrazepam. For drooling, amitriptyline, transdermal hyoscine patches, and glycopyrrolate, atropine, and benzatropine are used. For pathological laughing or crying associated with pseudobulbar palsy, amitriptyline or other antidepressant could be used. And riluzole, as we discussed, is used for the disease of bulbar onset. Other than this, there should be assisted ventilation and nutritional support in the form of percutaneous, endoscopic, or radiological inserted gastrostomy, and end-of-life palliative care.